Good evening, everybody. Want to welcome you all to this webinar on virtual reality. My name is Gus Mazzocca. I'm the director of the University of Connecticut Musculoskeletal Institute and a shoulder and elbow surgeon. I'd like to introduce our faculty for tonight, which is an all-star lineup. Amisab Iyer, who is the chief of foot and ankle service, assistant professor at the University of Miami. Probably more important, founder of the Ortho Mentor, which has really had some huge advances for medical students and mentoring. Antonia Chen, who's associate professor at the Brigham and Women's Hospital and Harvard Medical School, director of research there, tremendous educator in arthroplasty. We have Jeffrey Wong, who's chief of the Orthopedic Spine Service, co-director of the University of Southern California Spine Center, professor of orthopedic surgery and neurosurgery, past president of the North American Spine Society, and as quoted, connected to all levels of spine. Leanna Tedesco, star PGY3 resident at Columbia University. Dr. JP Warner, chief of the shoulder service at Mass General, shoulder and elbow fellowship program director, professor of orthopedic surgery at Harvard Medical School, past president of the American Shoulder and Elbow Society, founder of the Codman Society and the New England Shoulder and Elbow Society. Bill Levine, chairman, Department of Orthopedic Surgery at Columbia University, the current president of the American Shoulder and Elbow Society, editor-in-chief, the Journal of the American Academy of Orthopedic Surgeons, dedicated educator. Joaquin Sanchez Sotelo, program director for the Adult Reconstructive Shoulder and Elbow Fellowship, professor of orthopedic surgery at Mayo Clinic. Stephen Cherney, assistant professor, medical director, orthopedic trauma service line at the University of Arkansas. Large interest in studying virtual reality. Ryan Lohre, PGY5 resident at the University of British Columbia, has published research on virtual reality. And Mohan Khan, shoulder and elbow surgeon, assistant professor at McMaster University in sports medicine. So tonight, what we'll do is we'll have questions to our panelists. We'll be conducting some polls to keep everybody on their toes. We'll showcase some videos, and then we'll be able to take some questions from the audience via the chat room. Now I'd like to introduce Danny Goel, who is the CEO of PrecisionOS. He's the clinical associate professor at the University of British Columbia, shoulder and elbow surgeon. But I think more importantly, he's really quite engaging and dedicated to improving education and improving how we can really take strides to advance what we do and how we do it. He gave a number of talks at the University of Connecticut, which we all here became early adopters of this technology. He was able to send it to us during the pandemic when all of our ORs were shut down, and we were able to use this quite effectively to keep all of our skills going. So he's also really talked to us about a book by Anders Ericsson called Peak. They talk about purposeful practice, and that's something that we've adopted here at the University of Connecticut. So Danny's going to make a few statements.
Thank you, everybody. Thank you, Gus, for that introduction. So I want to thank everybody for attending today. I have a very brief presentation that I'm going to give, which will be less than 5 minutes, just to set the stage for what we're going to talk about here with all these different educators from around North America. So I'm going to discuss very briefly the challenge of surgical education as I see it, and I think as we all should see it moving into this new era. So first, I want to thank all our sponsors, specifically CONMED, the AO Foundation, Ortho Mentor, the Knee Shoulder course, and a new journal that you should become aware of called the Journal of Orthopedic Experience and Innovation, which basically likes to publish cutting edge and sort of new technologies and thoughts. My disclosure, as mentioned, I'm the CEO and one of the founders of PrecisionOS. Now, I think from a surgical and education standpoint, the one thing that we all know really well is we know what we need to teach, and that can be anything from shoulder to spine to arthroplasty and including foot and ankle. What I want to do with this very brief presentation is talk about how we need to learn and this idea that we need to spend, I think, more time on, especially in the context of VR and virtual reality training. And this idea known as metacognition. So the things that are currently absent in healthcare education is what Gus referred to as this idea of deliberate practice, where we give residents and surgeons and anybody who wants to learn anything the idea that they can have an immersive experience, which gives them data, allows them to fail and repeat, and then give them feedback during that performance measurement. Now, this is a bar chart, or pardon me, a line chart by Gallagher, who's a famous researcher in simulation, who looked at the difference in variation in learning between a traditional learning curve and for someone who's introduced into this proficiency-based or deliberate practice paradigm. Now, the other thing that's missing in our healthcare education is this idea of interleaving, where you can actually, variation of skill is seen in your practice or in your residency. And tennis is a good example. You practice a forehand or a backhand, and distributed learning is where you can practice the same skill over time. And that's essentially absent in our healthcare education sphere. And the reason is because all of us rely on this idea of coincidental exposure. And just before we got on the case, Dr. Levine was showing a case of a young person with a combined upper extremity injury. And the only reason he saw that is because he happened to be lucky enough to be on call when that patient came in. So our experience in healthcare is very random, and that speaks to the idea of learning curves. Now, this has been quoted multiple times before, this idea of Halstead, which he basically adopted this idea of apprenticeship, this see one, do one, teach one. But there's some interesting facts that I was able to identify when I dug deep into how this actually worked back in Johns Hopkins. So the assumption with this adage is that we all assume that all of us will succeed with this model, but the reality is that less than 15% of Halstead's residents actually graduated, and they became the thought leaders at institutions that are well known, including Duke, Yale, and Brigham. And so what we try to do with our current training model is we take a group of residents and we want to make them into proficient and safe surgeons with this idea that we have this concept of productive failure using textbooks, videos, sawbones, and cadavers. But the reality is none of those provide this idea of productive failure. And in fact, what we're creating is failure-deprived education for surgeons as they go into practice. Now, this speaks to this curve by Ebbinghaus, which says that most of what you'll hear or watch, you will forget at least 75% of it in about 6 days. Now, if failure is not possible nor an option, but failure leads to success, what are we doing with our educational paradigm right now? So there's been some change agents in combination with Halstead's education, in that the residents and trainees are getting less exposure, there's less surgical time, the first trial, and lifestyle certainly had an impact. And the things that have changed this are the Libby Zion trial, the European Working Directive, the first study, and the Bristol case. And if you're interested, I would encourage you to look at how these change agents have impacted how residents train currently and moving into the future. Now, if I was to summarize this in this slide here, the ideal situation is a resident would have a certain number of work hours. We would obviously have the apprenticeship model. We would combine that with deliberate practice, and you would have a certain percentage of certain competency. What's happened, of course, in the past is we had lots of work hours. So the residents, the reason they were called residents is they would actually live in the hospital with Halstead under his guise, and they would get very little deliberate practice. And I think that model, as I mentioned, has been absent from healthcare. And he graduated 15% of his residents. And what's happened over time today in 2020 is we have very little time. We have a modification of the Halstedian model, which has actually been modified in Boston, and we have no practice. The question that I would pose to all of you is how is this going to surface as we move forward? Now, VR is really asking the question is how should we learn moving into 2020? Now, I showed you the Gallagher curve before, and this is a study that we did, a prospective randomized trial with the Canadian Shoulder Elbow Society. We actually demonstrated that you can actually learn 570% faster and actually show improved technical skill when evaluated by members of the Shoulder Elbow Society. Now, a second study we did, again, measuring metrics against implant position, and we can share this offline with those of you who are interested, but we actually were able to show that your metrics in VR can actually have a direct correlation with implant position moving into the cadaver lab. So in summary, I think what I'd like to introduce is this idea of how we need to learn, but VR is really only scratching the surface, identifying the deficit that we need to address. I'd like to thank all our institutional partners who are currently using and adopting and attempting to integrate our technology into their organizations with their residents. And I think in summary, really what VR is trying to do is optimize the science of learning in a safe and low risk environment. And we've tried to take a very thoughtful and mindful approach to educational content development across specialties. And I'll close with an Einstein quote that says, once we accept our limitations, I think we can move beyond them. And with that, I will summarize and pass it back over to Gus.
Thanks, Danny. That was great. First question will go to Dr. Warner. Can you define the different uses of augmented reality versus virtual reality for us?
So there's a lot of confusion about this, and anybody who's interested in augmented reality, there's a whole Harvard Business Review article by Michael Porter about it. And you might imagine managing assembly lines by augmenting the reality you see and understanding things that may be missing from the processes. Basically, augmented reality is augmenting what you see with information about what you're looking at. Virtual reality is a little bit mixed there. We may do virtual reality when we do planning, which isn't real virtual reality the way we show it here, which is an immersive virtual reality that actually affects your physiologic response to a situation because you're immersed in the process. And then there's mixed reality, which is actually a form of virtual reality projected onto the world in front of you. And that's a whole nother area, and that's now being applied in a variety of different surgeries. So there's confusion between augmented and mixed reality, but in 1 minute, that's about all I can give you, and I think we can discuss that further if you want.
Great. Now we're going to get into a little bit of the educational format, and we have a video. That's displaced intertrope fracture. A lot of times it's confusing to see what to do just with the traction table. So the first thing we're going to do is take the bone out of the body. You're going to reduce it. So you can use all the... This is a medical student, and what we're showing is the ability to take the actual bone of an intertrope fracture out of the body, use the fracture table to reduce it so you can see it, practice those maneuvers, and then reduce it with the C-arm. This is the same medical student then practicing pin position for a proximal femoral nail. And what we're really trying to do here is have them look at the x-ray, understand three-dimensionally what they need to do and where to put the pin, and then work on that. This is one of our residents performing the Skiffy module, where you can see that they're off anteriorly. They realize this, readjust. Now they're a little bit better. And the beauty here of the purposeful practice is we can repeat this multiple times. So this has been very useful for us at the University of Connecticut, where we can really repeat multiple times the same difficult procedures. And in some people that don't have great three-dimensional ability, we can work on that three-dimensional ability where they look at the x-ray, study it, find out where their hand position should be, and then execute the procedure. Dr. Iyer, how can medical schools use this to increase musculoskeletal education?
So that's a great question, and that was a wonderful video. And I think it really highlights some of the challenges that our current system is actually facing. And if we think of it on a spectrum, one of the things that we're often missing and commenting on is the lack of musculoskeletal education early on in medical school curricula. And as a result, if we're able to integrate VR to help with the anatomy and applied anatomy specifically at a much earlier level, that can not only increase interest, but also help facilitate a better sort of three-dimensional understanding of what's happening. So when students start at a very early sort of MS1 level, then they actually get to their MS4 level and they're thinking about applying a residency, they have a much more keen sense as to how to be better prepared for when they're on away rotations and actually in the operating room. The other thing that it's, I think, critical to consider is in a timeline, in a landscape where we are moving towards changing how we evaluate students, this actually provides another sort of metric by which we could actually gauge who may have the actual surgical aptitude at a much earlier level. That is yet to be seen and yet to be determined, but certainly poses a lot of promise.
Great. Dr. Levine, how do you plan to use VR at Columbia for your residents?
Well, Gus, thanks for moderating, and Danny, thanks for doing this tonight. You know, I got a chance to meet Danny, and he gave a phenomenal grand rounds at Columbia, virtually, of course. And so we talked about it. He sent us over some of the sets, and our residents started using them. And, you know, I think it's, from my standpoint, I've looked at so many different VRs over the years and simulators over the years, and they all have been hampered by really not being able to be applicable beyond a very junior level. And so I've always been looking for something that where we can use it for more senior residents as well as junior residents, fellows, even faculty. And so that's what I'm excited about to continue to push this forward. And, you know, for us, I think it's an augment to surgical education and training, and something where, as Tabs just said, you know, to be able to get multiple reps and do it ahead of time goes along with Chris Ahmad's book, Skill. You know, there's the mental preparation that makes us better surgeons. And what about doing mental preparation with VR? How awesome is that? So that's how we're looking at it at Columbia.
Dr. Khan, you have VR at your institution. What metrics for success do you use, and how does that change our teaching paradigm?
Thanks, Dr. Mazzocca. That's a great question. Being in Canada, the Royal College has implemented a competency-based curriculum for all residency programs. So the metrics that we use for our residents' technical success directly relate to the ability of the resident to be competent in performing a surgical procedure or parts of the surgical procedure independently and competently. So for us, virtual reality is a useful augment to the traditional residency training program in that residents will be able to perform these procedures in a high fidelity environment and actually be able to demonstrate it to an attending surgeon if required virtually. And so it'll essentially speed up their learning. And we're also looking into using the metrics provided by the PrecisionOS system into potentially flagging areas of concern for certain residents or incorporating it into our OSCEs.
Perfect. Dr. Tedesco, how has VR helped you in an actual real case? Give us some reality here instead of Dr. Levine pontificating.
My last rotation, I was on peds ortho, and we had a skiffy case come in overnight, and I was able to, before the case, practice the skiffy module, just like the one you showed your residents doing, and I was able to do it you know, for 3 different degrees of slip, which was really helpful since it had been the first time I was doing this case. You're also able to pull the bone out of the body to see in 3D kind of how that slip actually looks. And for me, that was something that I wasn't quite able to do before I used this module. And so I was able to take these 2D images that you see in the virtual operating room, and then pull the bone out and get this 2D to 3D kind of translation, which was really helpful. And then that day I did the case, and I felt like I was able to get 3 reps in before I even had a hands-on experience. And so it's really useful for me.
Funny, it sounds exactly like what I just said should happen. Gus. How is that pontification?
You be quiet unless I speak to you, please. Dr. Lohre.
Hello. I'll keep on the trend of the skiffy model. I think it's a great example of how virtual reality can really help us because it's purely a 3-dimensional localizational skill. And it's infrequently done enough that sometimes we have challenges with them. And so recently at the Children's Hospital, we had a 15-year-old chronic severe skiffy come in who actually had an attempted surgery by a community orthopedic surgeon who actually wasn't able to place the screw correctly, had to take it out and ship the patient over to us. And so knowing this, I pulled out the VR headset and practiced the severe skiffy model. And then subsequently, after doing about 5 tries, was able to place 2 screws in, and they were very nicely positioned, I thought. And I was also curious then to look at how my performance increased over the time. So Precision has this dashboard where you can access your scores and actually see how well you're doing. And so I looked at how many fluoroscopy shots I took compared to this other failed attempt, and it was about 7 times less with 2 screws under supervision at the Children's Hospital, which I think is a very profound example of the benefits of this technology for myself, but also for, let's say, refresher training for someone who doesn't frequently do these procedures. And I kind of urge people listening to maybe consider this case in the future when some of the other topics come up, like Dr. Warner's segment later, because I think it's a very blunt and direct example.
Joaquin, do you see a need for virtual reality with your fellows? And if so, would it be earlier or later, or how do you see this fitting in with fellowship training?
Thank you guys for inviting me today, and thank you, Danny, for having me. There's no question that VR is going to play a major role in fellowship training. The potential is incredible. One thing we don't really consider sometimes is that it makes learning fun. So I must disclose that when I got the first set that was sent to Mayo, I was practicing with it at home, and I gave it to my 6-year-old, and she couldn't stop playing with it, and she wanted to learn the procedure, and she's 6. So when you give it to the fellows, they just love the way it feels, and I think it makes learning more fun. Specifically for shoulder arthroplasty, we now know that we have to really think 3-dimensionally, and this is a great tool to understand glenoid morphology, aiming with the screws or pin guides and so on. And also the instrumentation is getting more complex for different implants, especially augmented glenoids or newer humeral components. So the value is huge. In terms of when, I think all the time. For example, it will be a great tool in the interview process so that you can actually understand the skill level of fellows. It'll be great to understand when is it that you can move fellows faster in the progressive surgical independence. And finally, at the end of the rotation, you can use it as an evaluation tool. And I think Danny has really showed that there is a correlation between performance at VR and performance in real life. So no question, this is an amazing tool, and I'm super excited to use it in our program.
Dr. Wong, what about surgeons in practice? How does this fit to showcase technology or learn and improve?
Well, absolutely, it applies to patient or surgeons who are in practice. I mean, we constantly learn. There's a lot of things I do now in practice that I didn't learn in my residency or my fellowship. And so there's constantly new procedures, and the education of the residents and fellows absolutely applies to surgeons in practice. In fact, in spine, there's all these new technologies, and sometimes they're so new, if one of us needs to learn them, we're kind of starting over. We may know the anatomy from our experience, but we're kind of starting over from a very basic level. And so if this can improve education, it's certainly going to apply to people in practice.
Yeah.
So performance metrics were the lowest. Maybe what are your thoughts on that, given that you're one of the earliest users of VR?
Well, I think that whenever you have performance metrics, everybody starts to get a little uptight, and there's a lot of different issues that can also kind of come out of that. What we did was really try to get some of those early metrics out of there and then concentrate on just actually parts of the case. And then later on, what we do is we have them work on their own so they can, just like Dr. Lohre was saying, he can compare himself to himself. But I think that as we all try to improve, especially with teaching, that metrics kind of in an unbiased manner, I think will be very important. So we use those metrics pretty much because they can also show you where you hit or where you try to put the pin, and you can see if you have a cluster or if you're all over the place, which also shows about how you can read the x-ray and how 3-dimensionally you can adjust. Dr. Chen, what is it about cadavers that assumes it to be the gold standard for surgical education?
The hard part, I think, as educators, as orthopedic surgeons, we always need a gold standard. We always need a best one. And we always think that the human body, which is true, is probably the closest. So the best thing that you can have a student, a resident, a fellow do is actually work on a human body with you on there, But if you're a human, you don't want them to be working on you. So a cadaver is the closest thing. When you look at cadavers versus sawbones, that's probably one thing. You can't look at ligament tension, and I do hip and knee replacements. So assessing the MCL, LCL on a sawbones isn't going to be as good. A cadaver is going to be better, but they're hard, stiff. Even the fresh frozen ones aren't as good. But that's what I think people view as a gold standard going forward.
Dr. Lohre, can you tell us a little bit about some of the research you've published with virtual reality?
Yeah, happy to. Dr. Goel alluded to some of it briefly at the beginning of the segment, and really the immersive virtual reality literature has only come about and been published since late 2019 to 2020. And our study was one of the first, which is published in JBJS in the March issue of this year. And it was actually just highlighted as a OrthoEvidence ACE report. And so what it really showed was a significant reduction in learning time, but also in the ability of the senior orthopedic surgery residents that were trained in VR to actually accomplish a difficult glenoid exposure in a shoulder arthroplasty scenario while assessed by blinded orthopedic surgeons. And I think that's what makes the study very powerful, in that we picked as replicative of a real operative scenario as we could, and tried to show how well we can transfer the skill and the knowledge that we obtain in virtual reality. That is the ultimate goal of high quality research in simulation. And we also then now took that a step further with our next study and tried to look at, well, how can we quantify that transfer and then have downstream effects to healthcare, the patient, and how much time we can actually reduce training in the real OR by virtual. And we actually showed that we can save 47 minutes of real OR time by training with an hour in virtual reality. And I think that's very powerful in terms of patient care and cost.
Yeah, it's tremendous work. Dr. Cherney, what are you noticing are the biggest gaps for residents and fellows?
Thanks, Dr. Mazzocca. Well, I think that there's quite a few things. I think we've touched on a little bit of each in a way. I think one of the biggest things that I've noticed in my first 3 years on faculty is that it's really hard to get residents early autonomy in the operating room. We're not allowed to run 2 ORs at a time here. So it's really hard, and it's really important for us to be as efficient as we can as surgeons and taking care of the number of patients that we need to. So you can't just let residents figure it out on their own a lot of times. One of the other things that's really difficult I've found to teach residents is sort of the 3D spatial reasoning that's been touched on before, being able to convert the 2D images to the 3D reasoning, where their hands actually are in space, and then also picking up on the other things in the operating room, like the sound of the drill, and then a little bit of the tactile feedback, and then also just the pure number of systems that you need to be aware of. I think the number of systems and implants that go in, plus the number of surgical approaches, is only increasing over time, and I think all of those things combined are really difficult for trainees these days.
Yeah, that speaks to the next question. Danny, what's the state of haptics? Tell us what haptics is to begin with.
So yes, thank you, Gus. So the haptics is the idea of touch during surgery, and there's this it remains a very complex topic. And one of the things that I've sort of helped myself to understand, that I've referred to an expert in the field, which certainly should be applauded for a lot of the work she's done, is Dr. Carla Pugh, P-U-G-H. She's a professor of surgery at Stanford, and she's been studying this for the last decade or so. And so the idea of haptics is extremely complex. And the one thing that her and I have talked about, which is actually quite unique to orthopedics, is this idea of synesthesia, where we actually have the idea of sound, which actually can replace the idea of touch. So when you're drilling through bone or sawing through bone, but the bicorticality of that and the differences you can rely heavily on the sound of it than you would on the touch. And a really nice study done at Toronto, and expert trauma surgeons actually showed that to work, where they actually muted or blunted the sound, and the trauma surgeons actually plunged through the bone. So the answer to your question in brief is that it's a very complex area. I don't think we know exactly how it's going to translate. And the question really is, do we need it to be in a 1-to-1 ratio to learn how to become proficient surgeons? And I think the answer is unknown.
Dr. Khan, how do you allocate parts of the case to residents in the operating room? And what is your criteria for them to operate?
That's a great question. I think for me, a resident's involvement in a case directly depends on their ability to perform a particular task safely and appropriately. And I expect in general that a more senior resident or someone who's done a procedure prior will be able to perform more advanced aspects of a particular procedure. So for me, I begin with residents working with me on a particular basic task whether it's triangulation or just starting off with a diagnostic arthroscopy. And as they master that, I will then progress them through more complicated aspects of a particular procedure until they've mastered the entire procedure. So I think a resident that demonstrates competency earlier with basic tasks can then be advanced quicker. And as Danny showed in his research, that's one of the real benefits of VR, that it'll give the resident essentially a head start on their learning curve so they can benefit more in the real OR.
Good afternoon, everybody. This is Dr. Goel from PrecisionOS. I have many people in the operating room with me today. I have a surgical fellow, a resident, a physician assistant, as well as a medical student. And we're going to talk about some principles of a revision knee arthroplasty. So before I begin the first step, does anybody have any questions?
Yes, doctor. How do you know how much you're supposed to ream?
That's a good question. So as I pick up the reamer, you'll notice that there's a marker to tell me how deep I can go into the femur. Now the things that I'm feeling for and listening for are the cortical chatter of the reamer on the inner part of the femur. And you can see I can switch sizes of the reamer. This is a size 11. And it's sequential, and I'm listening and feeling for the cortical chatter of the reamer on the inner part of the bone. So I'll give a quick comment on that video. So the first part was obviously a pre-pandemic scenario, all those medical device reps training in VR, and the latter video was something you could do remotely. So theoretically, the way that technology is structured right now is if each of us had a headset, we could coexist in the same virtual space. And there was a question in the chat that I'll just comment on about mentoring, and I think mentoring is extremely important. With VR, there's no tool that lives independently, and Gus, you've shown that with what you're doing with your residents. It doesn't live in a vacuum. It has to be combined with the mentorship and the time that you would spend with that resident to get them to a level of competency and proficiency.
Yeah, and I think one of the most powerful things when we have this idea of casting, where the resident or the trainee has the Oculus glasses on, but it's connected to the computer. And that's what we were trying to show in our video, was that I'm looking at the computer and actually for the first time, I actually see through the eyes of the trainee, which is really powerful because there were issues where I didn't understand why they may be struggling, and I wasn't really good at teaching them what was happening. But when I see through their eyes how much time they spend looking at the x-ray, or what they're doing with the x-ray machine, or how they're trying to reduce, then that gives you a little bit more insight. So I also think that for people that haven't used the glasses or have been in the virtual reality world, it's amazing how fast you and your body assimilate to that area and to that world. I thought that was the most profound thing, because I was watching commercials and you see the videos that we're showing. And for those of you who haven't been on it, it looks like, regular animation. What's the big deal? But when you're actually in that world, we've had our guys and myself have actually dropped the handset because you really believe that those are your hands. So I think that's very powerful as well. One of the things that will be coming in the future is also the ability, or the idea is that when you're going through a procedure, much like with flight simulators, you can simulate problems, which I also think will be extremely valuable. So as you're going through a case, you can simulate certain disasters and then practice the management of those disasters so that people can become much safer and much better at handling surprises.
Gus, can you pause for 1 minute? I just want to make a comment about that.
Yes.
How many people in the audience would say that it's a value that the pilot who flies the plane you get on did simulation training? And how many would say, nah, it's not important. I'm sure the pilot's fine, because they never simulated the kinds of crises they might have to deal with. suddenly. And so you can see the value of this, what we take for granted, but how relevant it might be in a surgical setting.
So we can see there that, obviously most of the people really believe that learning from surgical techniques will be enhanced by virtual reality. Dr. Cherney, how can VR help educate other important members of the surgical team and prepare them for cases such as OR nurses and techs?
I think that this is a really interesting way to apply this technology. It's not, I mean, we're all orthopedic surgeons, or many of us are orthopedic surgeons on this panel and in the audience, but the reality is that it takes an entire team to get through your day. And it's pretty obvious when you have somebody that's not familiar with what's going on in the OR that can make or break your ability to get that last case of the day done. And I have a friend that just went through onboarding at our hospital. And another thing is the cost. They opened up a huge number of trays just to get this person familiar with the implants. And, there's potential that you spend $50 to $100 to sterilize each one of those trays. That adds up over time for each person that gets trained at the hospital. So having that tech be able to train virtually may be a great way to get them involved. And it's also not just the tech, it's potentially the circulator as well, to better understand what you're doing. And when they're adjusting the traction of the leg, for example, they may not understand why you're doing that or why you're asking them to internally rotate or take some traction off or on until they actually saw it themselves. So I think that it's a great option to help increase everybody's understanding of what you're trying to accomplish in the operating room.
I think if I can just add a comment, Gus, as a question from the audience, which actually relates to that, which I'll pose to the panelists, but it says, how important would it be for the training to show where the highest stress points are during the procedure, which cause spikes in blood pressure, heart rate, and potentially impacts the clarity of decision-making? So maybe I'll pose a question to Dr. Warner, because you mentioned about the physiological response. So what are your thoughts around that, Dr. Warner?
So, I mean, look, at the end of the day, what we're talking about is bending the learning curve. There is a cost curve too we can talk about, and I commented on that briefly, but the learning curve is how long does it take you to get better at a particular task? How fast can you do that? And part of that is simulating the kinds of problems that commonly you see when you train people on cadavers or in the operating room in the real world. And you can actually focus energy, not on the easy parts, but the hard parts, and then address a given VR module to simulate those problems and be prepared to show people how to do exactly what you were saying before, Danny, learning from error and dealing with that to do it better before you get to the operating room. I think we're going to see more studies demonstrating the utility of this in shortening the time to learn a given step and reducing the chance of error, whether you compare that to a cadaver or what you see with residents or doctors in training in the operating room.
Back to you, Dr. Warner. What about the relevance of training or highly skilled OR industry reps?
This raises a number of questions, but brings into play a number of stakeholders. The first thing is the return on investment for training reps, and you just saw that video. How do you get all the reps in a short period of time to become truly expert at the procedure that they're going to be watching and helping people undertake and do? And I think Danny can speak to that, but that's a very important role here. The other thing is it allows them to be more aware of the problem surgeon have, tier 1, 2, and 3, what they need, and adjust accordingly how they approach a given procedure and particular steps in that procedure that are particular pain points. They can simulate those. It also allows them to engage with the support staff, and in doing so, they kind of integrate care between the rep, the support staff, and the physician. And, ultimately, I think at the end of the day, this will manage personnel costs.
On the same lines, Dr. Wong, what role does a rep play in the OR where there is new technology that's being used?
Well, the rep is pretty critical, especially in new technology. A lot of the new technology is built around sort of implants, and they're the ones that kind of know the steps. Everyone in the OR has kind of got a lot of things going on and they have multiple jobs, but the rep is singularly focused on that technology. The other thing about it is that if it truly is new technology, the reps are a wealth of experience because that's what they do. They're in the operating room every day, not necessarily your hospital, but they're going to all different hospitals and they're getting that experience. And even though they're not doing those cases, they're seeing the things, they're seeing the pitfalls, they're seeing the mistakes, they're seeing things that are the stress points, right? They're seeing when things go wrong and they know how to deal with it, and they see how people deal with it. So they're a wealth of experience, and they have to really know their stuff, especially when it comes to new technology.
Dr. Chen, when learning a new technology, how should a resident acquire that knowledge?
I think it's very similar to what Dr. Khan said about how much you let your residents do. You start with the basics. Now, the scary part is most of our residents have way more knowledge about new technology than we do. And so you're in the operating room and you're looking at your smartphone and they can tell you 10 different features on their smartphone that you're just learning from them. So sometimes they'll actually pick it up pretty quickly. We recently had a learning session for how to teach residents better on the millennial learner. And you got to meet them where they learn, essentially. And I think technology is exactly where we're headed to. They grew up with technology. You know, the rest of us didn't have cell phones growing up, and now they come in with cell phones. So when it comes to teaching residents, I start with the basics. You know, I teach them what I know, I would say, about a new technology. And it's always back to the basics of the original principles. So you still have to know the basic principles that we all learned, you know, angles, you know, alignment, things like that. And then use technology to improve their education and enhance their education as opposed to replacing the original education. So you can help them visualize something better. People are sometimes visual learners. That would be beneficial with new technology. Basically craft a new technology to fit their learning style so that they improve what they can do.
Dr. Levine, how do you decide how much a resident or a fellow gets to do in the OR?
Well, the best residents and best fellows, in my experience, Gus, will actually give me a plan of what the surgical day is going to look like. So today we did 8 cases, and my 4th-year resident sent me a plan for all of the surgical cases that he was going to participate in, as did my fellow in the other room. And that does so much as a mentor when you see that the mentees have actually thought about what they want to do ahead of time. They've told you what they want to do. They tell you which parts of the case they think they should do, and then we can have a discourse about that. And so for me, it's about that. It's about pre-op planning and communication and being transparent. And the more they do ahead of time, the more they do in the OR. And the more they show that they're competent in the OR, the more they get to do. So it builds on itself.
I was just saying that I'm wondering right now how much Dr. Levine will let me do in the operating room with him. But I follow the same principle. And I think the most important thing is, first off, that you care enough to think about the case, whether you're doing foot and ankle or shoulder, elbow, or whatever, you know, hip and knee replacement or whatever it may be. And you have thought about the patient, you thought about the comorbidities and thought about the case at hand and how you, if you were the only person in the room, how you might tackle it. I always send, and I've been doing this for 5 years now, I have notes that I've compiled from the tail end of fellowship up until about a couple of years ago when I first started, that I send to the residents. And they have me at those stress points swearing at myself in my notes, oh, don't do this, don't do that, and all the applied anatomy as well. And that's the thing to me that allows me to decide, hey, how much can I let them do? It's a matter of, A, do they understand the fracture, the pathology at hand? B, do they understand the relevant anatomy? And can they safely work through a portion of a case necessary to do whatever correction we need to do in order to optimize the patient outcome? When they can demonstrate their involvement with the case and sort of really plant those seeds of mentorship in addition to the discussions we've had, that really allows me to let them go that much further with their involvement in the case.
Those are great answers. Great answers. Dr. Tedesco, how does VR compare with cadaver and simulation for you personally?
I think, as Dr. Chen said earlier, cadaver work is our gold standard, and I think that's probably one of our best opportunities, but I see VR as an excellent augmentation to that. You know, cadavers are not always available, especially with the pandemic. We have been limited on our education resources and what we can do. So having this VR simulation has been an excellent augment for me personally to do mental rehearsal of surgery and then deliberate practice of different cases that I may be doing in a day. And as we've talked about a little bit, you know, simulating the stressful parts of the surgery and then having to think through it. And, you know, you're on your own when you're doing the VR, except for, you know, the VR itself. So it gives you a really good opportunity to you know, make your own clinical decisions in a low risk situation. Obviously, there's no real substitute for cadaver work, but I think that using the VR system to augment any cadaver work you do is really beneficial for residents of all levels.
Dr. Lohre, how prepared are you for upcoming fellowship? And what would you be looking for in fellowship you've chosen?
Boy, well, I hope I give this answer this question a good answer, because he's here listening. But really, considering I'm graduating from a Canadian residency program, and I think you can apply this to anyone in North America, they're all competency based. So essentially, I will be a competent surgeon, but what does that mean? And I kind of have insight into that now, and how we learn, and kind of objectives on where people can go in their learning patterns and trajectories. And so I think a strong fellowship is one that provides someone with a push. So a push to have as many case variability as they can to push their understanding of the pathology, and to try to provide some new understanding and evidence around that pathology. So essentially, it's a hierarchical progression from competency through practice to proficiency on the way to being an expert. So that's what I'm looking forward to.
So want to refer back to the remote education video that was shown, where all the different players were in the OR. Dr. Khan, with the pandemic and what's going on with reductions in travel, how are you going to try to keep proficient and your education up with this new world we live in?
Yeah, that's a great question. I think with the COVID pandemic, I think many people, including myself, are quite hesitant to travel, particularly outside the country, for risk of exposure. Plus, with the potential for required quarantine on returning, and with busy surgical practices, that can be very detrimental. So I think for me, I'll be doing more Zoom type conferences over the next year, as well as using more online resources. I think VR has a really great role to play potentially in that conference attendees could potentially have a immersive experience, just like a regular conference to a degree. And for us, with surgical demonstrations, literally everyone could have a surgeon's view of a particular case or procedure, as Danny has shown in the video. So I think there are a lot of advantages to that.
Dr. Chen, you educate a lot. How will this impact your ability to teach others in different regions?
Very interesting. Prior to pandemic, I would travel to different countries and operate in some of these countries, and people are hungry for knowledge. In the US, I think we have a glut of information and a glut of knowledge, which we're lucky to have. We can travel to these courses. We can do cadaver courses in our backyard. We can travel to other surgeons and watch them. And other countries don't necessarily have this ability to do so. So we would travel there a lot as Americans and Europeans and cross-country, cross-continental areas. But with the VR technology, you saw it, everyone's in a room together and they can be in far-flung parts of the world. So I think this is game-changing. We realize that travel right now is obviously not the safest, and who knows if it ever will be truly safe again. But do we have to put the carbon footprints out there and travel for 12 hours, 14, 16 hours on a plane? Do we have to take time out of our clinical schedules, time away from our families? Can we actually do this in a virtual setting? And I think the answer is yes. So this has a big potential to be a paradigm shift with regards to inviting people into your operating room, for example, and walking them through a case that you would normally have to do in person, and actually everyone getting a chance to, let's say, manipulate the bone, manipulate the leg, change things, do things. And if you mess up, guess what? It's okay, you can reset. So I think this is going to be a game changer in the terms of actually surgical intervention. Courses are different. We've all learned how to do Zoom meetings like this, where we can all talk to one another, but there's something very different of getting hands-on than just hearing about it.
Yeah, that leads into our next question for Dr. Warner. How would you convey technical skill through these online forums, such as webinars?
Well, it's all about differentiation if you're a company, and it's all about engagement if you're an educational entity. And so these are very fatiguing to listen to the Zoom things and such. And when you engage the participant, whether you're a company or you're an educational entity or whatever, you get much more focused attention. It's deliberate practice, really. You saw how we can put people from distant places in the same room. And so there's enormous opportunity for professional education as it's applied by companies. And also we're going to go to more of these Zoom meetings, these are going to get extremely fatiguing if this is all we're doing. However, if you put on your headset and, you know, you go to the room with somebody and then people are watching you do, and you get to do the procedure, think of all the possibilities you have to stay engaged in the process and more focused on a task-oriented approach, which you blend also with the information that you give people about why you're doing it in the first place. So this is a new paradigm. It's a true paradigm shift. I want to just briefly comment that if you look at who the late adopters are and who the early adopters are, the companies that stand to benefit from differentiating their products and creating greater sales, if you will, they're going to be the early adopters. The large academic medical centers are inherently the late adopters. And so the direction here will be industry will show the value of this, and it will gradually percolate into the educational, you know, fabric of how we do things.
Dr. Sanchez-Sotelo, how about internationally where cadavers may not be available all the time? How do you see this technology impacting those areas?
Well, I can tell you guys that when I was a resident in Spain many years ago, there was no cadaver training. So when cadaver courses came out, they were a revolution. But even today, when I go to South America or some areas of South Europe, you can only get a cadaver course if it's industry-based, and it's typically very expensive. So VR has the potential to complement or maybe replace to some extent these courses. I think it's important to realize that companies that are interested in this technology may need to think about how you adapt to a different language, for example, or how do you adapt to implants that may not be available in their country. And like Dr. Chen mentioned, there is a huge role of mentorship. So you could basically do a cadaver dissection virtually from your hometown, and then everyone can participate somewhere else. I also see here potentially as a humanitarian mission, like a way to train countries that have truly no access to education. And I think shipping a VR set is way cheaper than many of the other efforts that can be done to train doctors in Kenya or places where there is less access to education. So huge potential.
Yeah, that's fabulous. All right, we're going to a anatomy video now.
Actually, Gus, before you go there, I want to, there's a question asked by Dr. Pugh, who I referenced earlier. And the question is, the concept of performance metrics can be greatly improved with proper marketing and process. Process should include data from longstanding practitioners with the best outcomes. And feedback should be based on critical decision and technical subtasks. Final, total procedure scores are less useful. So there's several, I agree with her entirely. There's several unknowns here though. To date, we have not been able to objectify performance in surgery, specifically in orthopedics. So I don't know if when, you know, Gus, you say 10 degrees of anteversion or Dr. Sanchez-Sotelo does, I don't know if everybody agrees on what that means to them. That's the first thing. The second thing is, unless everybody's measuring outcomes, we don't know who is having the best outcomes. And this speaks to the idea of value-based care, where unless we're measuring outcomes, we don't know the value that we're providing the patients from beginning to end. So, you know, to answer your question, Dr. Pugh, and I'd be interested to see if any other panelists have an answer to this. I think we have work to do to establish ideal performance metrics based on high volume and high quality performers.
So I think that that anatomy video really does a lot of justice, because I think what it really allows you to do is be able to see it in a hands-on form, then see it in X-ray, and then do various reduction maneuvers, looking at how the bone reacts to that. Also, as Dr. Tedesco and Lohre were talking about the skiffy, which is not very common, you get a great understanding of what that looks like and how it is in real life, whereas normally we're just seeing it through radiologically. So I think that's probably one of the most impactful things with the anatomy. Dr. Cherney, how can virtual reality take us to the next level and advance what the AO has taught us about trauma education? Speaking about 3D spatial reasoning and skill development.
Thanks. I think it's actually really interesting because almost all of the orthopedic surgeons that have trained in North America at some point likely have gone to some sort of basic trauma course. And they're really good for teaching the principles, and they're really good for teaching some basic procedures on synthetic bone models. But what they don't do is they don't replicate the 3D spatial reasoning like we've talked about before. I think multiple speakers have mentioned. That really doesn't come across in those courses. It's really easy to find the start site for a tibial nail when the tibia is disarticulated and sitting alone without any soft tissue. So how do we teach that to our trainees? Well, high fidelity models are disposable and really expensive. Cadaver courses are also really expensive. The alternative is to learn on the fly. And we've already talked about how that's really not palatable either these days. So I think that what I've found in using the precision system is that it really does replicate your ability to position your hands in 3 dimensions in space and then correlate that to what you're seeing on the screen, either by disarticulating the specimen, which you can't really do in real life, or the x-rays. I think it's really interesting. And that's just in 2-dimensional reasoning. I think it's even more complex when you think about applications like for percutaneous pinning of the pelvis, where you're no longer working in orthogonal plane fluoroscopy, your inlet and outlet view, instead of being 90 degrees off, you're only maybe 60 degrees off. It's an entirely separate level of complexity that it's really hard to get across to trainees. And I think that virtual reality is really primed to step into that sort of role.
Dr. Wong, with spine being so complex, how do spine surgeons really acquire that 3D spatial sense?
Yeah, I agree with what Steve said. You're not going to acquire that just by watching videos. You're not going to acquire that by just reading anatomy books. You have to acquire it through experience, repetition, doing cases. And the next best thing is practicing. And if you can practice through virtual reality and do it asynchronously when you have time, at night, whenever your schedule's free, and you can do it, and it gives you that real sort of sense of that anatomy and how you're applying it, I think that's a big win. Because I'm trying to get better at golf. I can watch all the golf videos I want. It's not helping. Unless I go out and hit the ball and play, I'm not going to get any better. And the same thing with surgery and the anatomy.
Dr. Chen, how do you teach anatomy during surgery?
So I'm going to just add to what everyone else is saying, but I think actually the most impactful thing for me when I was a student is to be pimped. So when I'm asked questions, I'm going to remember. So this is where you can all put on a headset. You can all say, okay, what's this? What's this? And that's what's this. And that's how I teach anatomy when I'm operating. Now, I operate on pretty simple parts of the body. So if they don't know ACL, PCL, we've got to talk. Or if they don't know femur, tibia, and the knee, again, we've got to talk. But it's one of those areas where if you are asked the question, you're likely to remember. So that's how I teach anatomy in real life situations. And that's what I like about things like VR, because it gives you a real life situation as opposed to just reading a book or going home and studying it, because we've all been there before. We've studied and memorized, and we're good at memorizing. But if you want to recall on a regular basis, and I think to what point that other people have brought up before, if you mess up, that's even the more interesting thing, right? So if I give you a saw, in a virtual setting, and you cut the MCL, and I say, well, what did you just cut? And they know, and then they would know what happens and how to fix it and things like that. Those type of real-time anatomy discussions, as opposed to just looking at a cadaver, are much more interesting.
Yeah, absolutely. Speaking of complex layers of the foot, Dr. Iyer, that's been tried to be taught to me for over 25 years, and I still don't have them. But with all of that complexity, really, how are you trying to teach foot and ankle surgery to your residents?
That's a great question, Dr. Mazzocca. And I would first, I'm going to digress for 1 second to say, when I was a first-year medical student, I was planning on going into pediatric oncology. So when we were in the cadaver lab and I was paying attention to anatomy, I really wasn't paying attention to anatomy. And now I harp on the students and the residents that I work with that it's anatomy, anatomy, anatomy. So so going back to what I said earlier, I usually send notes out, especially for to really highlight the intervals that I'm working through, because there are many sort of landmines, as I like to call it, structures that you have to be really, that are pretty tenuous, and especially depending on the patient population and the soft tissue envelope at hand. So when we're going through the case, it's pretty much, hey, if they know the basic interval start before we cut skin, then we actually make our way through the initial dissection. Then it's kind of pointing those structures out, noticing variations in neurovascular anatomy, dissecting around those, and then kind of working layer by layer to really reinforce every single time what the pros and pitfalls are as we make our approach. And I think as they do more of the cases, and even as I see more and more myself, as Dr. Wang was saying, it becomes that much more easy, where you know what to avoid and you know where you have to go in order to get the case done.
Fabulous. So, Dr. Wang, how will NAS use VR to add value to its members?
Well, I guess I can comment on how I'd like to see him use it. I mean, NAS is all about education. They do courses throughout the year as well as the annual meeting. And with the pandemic, it's been devastated. I mean, everything's been canceled. The annual meeting's gone virtual. And we just talked about just watching videos on Zoom is not a great way to effectively train people. And so I'd love to see them sort of be able to convey the same amount of education that they've done historically, but I think through the use of VR, maybe do it more effectively. And obviously, if the pandemic continues and everything's more virtual, it's critical. But even if we get through this, we get a vaccine and things kind of go back to normal, it's going to be at least hybrids from this point on, a hybrid type meetings. And so it's critical that you engage that audience that's online, that's not present right there at the meeting. And so I'd love to see NAS use that to enhance the educational process.
Dr. Chen, anything from the AUKUS?
We just announced that we're going hybrid this year for our meeting in November, meaning we're going to have virtual sessions and we're going to have in-person sessions. So the in-person sessions are going to mostly be the talks. And what's kind of sad is that we're going to miss out on a few of our tried and true. We have a residence cadaver course that's actually really fun and really engaging. We had some other courses on ergonomics that we were going to engage in the women in arthroplasty group. So this would be a perfect way to show different maneuvers, different techniques, things that we could do in a virtual environment that we could apply. That would be great to do this year. Unfortunately, it's probably a little too short notice, but this is where we can use it to do hip and knee arthroplasty and show different approaches. And again, to what everyone's saying, make the mistakes virtually so you don't make them in real life.
Yeah. Dr. Levine, American Shoulder and Elbow Society.
Yeah, so Gus, I think you mentioned earlier, we were planning on having PrecisionOS at the residence course, which we had to cancel. We have a fellows course as well, which we were hoping to showcase. So, I think that the future, as JP just said and Jeff said, is really critical. That there's going to be less travel in the future. There's going to be a lot of looking at, why do we travel as much as we do? Why do we go across the world and do what we do when we can do things like this? And this is just I think this is the best iteration right now, but think where we'll be in 5 years. It's going to blow this away, and I hope Danny's leading that charge as well. But I think we're just at the tip of the iceberg for how education is kind of going to completely be turned upside down. And the mentorship that we provide will be turned upside down in the next 5 years.
And then just finally, JP, you really are a champion and talk a lot about value-based care. Can you try to talk a little bit about the value of virtual reality for education and professional development?
Well, I mean, there are a number of things you can say about it. I already talked about bending the learning curve. We certainly can bend the cost curve as it relates to the cost of education, et cetera. But, I mean, imagination is where we go with this, and you've seen a glimpse of it so far. Imagine a world in which you literally can have an online coach available to you in a VR world, and you're in China and somebody's in, I don't know, any city in the US, and you
Boston.
Can link individuals with a difficult problem and have them in the same virtual operating room where one is helping the other solve a problem that he's got to go deal with the next day. And what is the value of that to the patient? What is the value of that to the system? What is the value of that to the company who provides the products for that person? The cost, the customer acquisition cost, if you are from a business point of view, without having to go there and have cadaver labs and et cetera and all of that, go way, way down. And the cost of education similarly goes way, way down and the engagement goes up. So there's value everywhere here. It all depends on the success of this as a particular avenue for development. And with that success will come the ability to realize all the imagination of what we can do to improve on all levels. So that remains to be seen, but I think Danny will maybe the next one of these webinars we do, Danny will have more to show us.
Yeah, and that about finishes up for us tonight. Danny, any closing comments for us?
Yeah, I want to thank all the panelists and certainly all the attendees for attending this session on VR, but more importantly, where we think surgical education is going to go, and whether we like it or not, our reality has changed. You know, we're in a new state with the pandemic, and we need to think differently. And perhaps it's been somewhat of an advantage for us to think about how we're going to evaluate each other and our residents and trainees as we move into this new era. So thank you very much, and always available to answer any questions after the presentation.
All right. Thank you, everybody. That was tremendous. Appreciate everybody's time.